Howdy, y'all. I'm Dr. Jeff Jarvis, and I'm going to talk some airway management in cardiac arrest because I know you have been sitting there going, my Lord, what does literature say about which tube, if any, to put into an airway in cardiac arrest? I know you were saying that because I could hear you. And hey, I'm a caring sort of guy. I care that you want to know about the literature. It makes me a very happy medical director, so let's talk some literature, shall we? Let's get right into it. So the way I'm going to approach this is I'm going to go over some clinical questions. So this is a list of the clinical questions that I have. I want to know, do we need to do any sort of advanced airway management at all? That's AAM. And by the way, if you're wondering about this abbreviation, AAM, it seems to be a thing. But if you're wondering about using AAM with drugs, the thing formerly known as RSI or RSA or RSD or DSI or DFI, any of those things, no, it's not known as that anymore. It is now known as drug-assisted advanced airway management. Yes, that's right. We're talking about that damn procedure. Okay, so maybe it's just me that gets cracked up by that. Either way, these are the questions that I want to go over with this lecture. Do we need any sort of advanced airway management at all? Does the timing of it matter? Well, if we're not going to intubate early on, what should we do in the meantime? Does the type of airway management have anything to do with epinephrine? Because one thing we know about epi is if it's going to have an impact, it needs to be used early. So does the type of airway management we use have an impact? What about if we just use a BVM on everybody? We don't intubate anybody, we don't do supraglottics, just bag them all. Does that make a difference? Well, if we're not going to bag them all, should we intubate or should we use a supraglottic? If we're intubating, does first pass success matter? Does using a bougie matter? Does using VL matter? These are all good questions. What do we do once we have the AAM in place? And then the final question that I hear all the time, what do we do with that ITD thingy? ITD thingy, we got some literature for you. We'll talk about it. So let's start off. Do we need any advanced airway management at all? So the research that comes from this is really about bystander CPR and what we know about that. So when looking at bystander CPR, if we're comparing compression-only CPR to conventional CPR, conventional CPR, what we see is neurologically intact survival, 40.7% with compression only versus 32.9% with conventional CPR. That is an adjusted odds ratio of 1.33. Now, because I cannot help myself but explain a little bit of statistics, let's just do a reminder of what an odds ratio is. An odds ratio is the ratio of the odds. In other words, if you have 40.7% of people in compression only surviving, and you compare that to the 32.9 with conventional CPR, you take your 40.7 up here and you put your 32.9 down here and you divide them out and you get 1.33. Now, if you actually do that math, it's probably not exactly 1.3. It's pretty close. But that's what the odds ratio is. The A for adjusted odds ratio, that is a way of doing this fancy regression analysis where you control for other confounders. So we know that the older you are, the less likely you are to survive cardiac arrest. We know that the longer you were down before you had CPR start, the less likely you are to survive. We know that if you're in a shockable rhythm versus a non-shockable rhythm, you're more likely to survive. Maybe there was more VFib in the compression only than in the conventional group. So that's how we control for those things. So adjusted odds ratio is another way of saying all things being equal, the odds ratio higher with compression only. So how much higher? What does that mean? Well, an odds ratio of 1 means there is no difference. It'd be like dividing 50 by 50. That equals 1. So Odds ratio higher than 1 means it favors that thing. Odds ratio of between 0 and 1 means it favors the other thing. You're less likely to survive. So here, that means your odds of survival are 33% higher with compression-only CPR than with conventional CPR. All right, well, let's take another study. This was a study done in Arizona by Dr. Bobrow and Dr. Spate, and what they found, compression-only CPR survival rate of 13.3. Again, this is functional, neurologically intact survival. You compare that to conventional CPR, the pumpy, blowy, 7.8%. And if you compare that with no bystander CPR at all, 5.2%. So if you look at odds ratio, adjusted odds ratio again, compression only versus standard, 1.59, 59% higher odds. Compression only CPR from a bystander standpoint, where you're not doing any airway interventions, is associated with improved neurologically intact survival. So what about in the setting of professional rescuers? There we are now on scene. So we're going to go back to the state of Arizona, where Ben Bobrow and Dan Spate did some great cardiac arrest research. We were just talking about their work with bystander CPR. They instituted minimally interrupted cardiocerebral resuscitation. This is where they did delayed intubation. So they did no intubation, no mask ventilation, passive oxygenation only for 6 minutes. Then they would go ahead and intubate. So they delayed everything by 6 minutes, any sort of airway management other than oxygenation. Now, they also focused on minimally interrupted compressions, early defibrillation, getting right back on the chest as soon as you defibrillate, not waiting for a rhythm check, and giving epinephrine early. And what did they find? So this is all comers, shockable rhythms and non-shockable rhythms. They found survival 4.7% with the standard CPR, early intubation, do a rhythm check, 17.6% with this MI CCR, delayed intubation. That's an odds ratio adjusted for the things of 8.6. So that is 760% higher odds of survival by doing these things. This certainly suggests that delayed intubation is a good thing. Well, let's take a look at how timing impacts survival in the hospital. So this was in hospital arrest, all in hospital arrest, looking at around 670 U.S. hospitals. And they grouped all of these patients by those who got intubated and those who didn't. So this was not a randomized controlled trial. I think that's really important. What that means is that perhaps the group who got intubated was different than the group who didn't. And the most likely difference is, well, if you got pulses back before you had time to do the intubation thing, well, your odds of survival are going to be higher just because of the limited amount of time you're in arrest. That's something called resuscitation bias. Resuscitation bias is a huge issue in non-randomized controlled trials dealing with cardiac arrest, and it's why randomized trials are so important. There are some ways to try to adjust for that, and the way they tried to do that is what's called a time-dependent propensity analysis. And what they did, their propensity analysis, is if they had one patient who was between 65 and 70 and a male with coronary artery disease, they would match him with another male between 65 and 70 with coronary artery disease. One patient with shockable rhythm, match it with another one. So that is another way, other than regression analysis, of matching for confounders. But they also tried to deal this with a time-dependent issue to approach resuscitation bias. And that means they did those comparisons also for this person was in arrest for 1 minute. We'll compare those with other people who are only in arrest for a minute, 2 minutes, and so on. So that's the concept of a time-dependent analysis. So in other words, they tried to address this resuscitation bias. They had a ton of patients, 108,000 patients. What they found, all survival outcomes, meaning ROSC, sustained ROSC, survival to discharge, neurologically intact, all of them decreased if the patient was intubated. So, what can we tell from this? I think overall, at least early on in the resuscitation, early advanced airway management, probably not so good. But we also probably cannot delay forever. Now, what should we do initially if we're not going to do advanced airway management? Remember that study that looked at minimally interrupted cardiocerebral resuscitation. So the Arizona study delayed intubation for 6 minutes, early defib, early epi, minimally interrupted compressions. Well, the concept of doing delayed intubation and passive oxygenation was so new in Arizona when they did this study that a lot, and this was a statewide, or I'm sorry, it wasn't a statewide process. It was in multiple large cities, so Tucson, Phoenix, and some of the surrounding areas, that a lot of the paramedics just said, not gonna happen. They need that life-saving intervention. We're not just gonna do this passive oxygenation thing, you're smoking crack. They said, all right. Just don't intubate. If you absolutely positively must do something, then bag them. Okay. So in a secondary analysis of the trial that I shared before, they actually said, okay, of those patients who did not get intubated early, let's break them up into two groups. Those who got the passive oxygenation that we wanted them to get, and those who the medic just couldn't stand it and went ahead and bagged anyway. And roughly speaking, a majority, 55%, the medic couldn't help it and bagged anyway. 45%, they went ahead and did passive oxygenation. And the way they did passive oxygenation, same way we do it, oropharyngeal, airway, non-rebreather, all the way on. What did they find? Functional neurologic survival, neurologically intact survival, walking, talking, back to normal. 38.2% in the passive oxygenation group, 25.8% in the bag valve group. They lumped those together, did the adjusting for the things, adjusted odds ratio 2.5 with passive oxygenation. So 2.5-fold improved neurologically intact survival, passive oxygenation versus bag mask ventilation. So what this is telling us, if we are not going to intubate early, and there's definitely evidence that we shouldn't intubate early, that we probably don't need to be bagging. We have talked many times in the past about epinephrine, and I'm not going to go into that again, other than to say the earlier you get epinephrine in, the more likely you are to have meaningful benefit. So I'm just going to leave the epinephrine comment in this airway management lecture alone. And let's ask the question, does the type of airway management, meaning intubation or supraglottic, does that impact your time to epinephrine? So the way we looked at this is a secondary analysis of the PART trial. So the PART trial is a randomized control trial that we're going to speak about in a little bit here that looked at King LT versus intubation. So that's what that was. A secondary analysis is when you take data collected in a randomized control trial and then do another analysis, an analysis that wasn't part of what they randomized for. And so what they looked for here is to see whether the type of airway management, King LT, intubation, whether that affected the time to epinephrine, and then whether that time to epinephrine had an impact on survival. 49% was intubated, 51% had a King LT. Pretty even groups, exactly what you would expect if they were randomized to those things. Now, what we found is the device does not impact how quickly you get epinephrine. 9 minutes with intubation versus 8.6 with LT, that's essentially the same thing. And they measure that from time of arrival to first epidose. Now, what they did find is they looked at, regardless of type of airway device, did early epinephrine, i.e. within the first 10 minutes, have higher survival compared to later epinephrine, meaning longer than 10 minutes, and they found it was associated with higher survival. Adjusted odds ratio 1.36. So again, early epinephrine probably makes a difference. And what I will tell you here is that this was 72-hour survival, not neurologically intact survival. But still, early epinephrine had more of an impact than late epinephrine. And again, that was not epi compared to no epi. So it doesn't look like your type of airway management has an impact on epi. So we've looked at the time, whether we should do anything at all. And then we've sort of admitted we got to do something at some point, but should we just bag them all? Don't do any of that invasive stuff, just with a two-handed seal, of course. So the evidence on this started off with observational data from registries. So this study by Hasegawa and his colleagues was published in 2013. This was a study of a massive Japanese cardiac arrest registry. So this is a registry of all out-of-hospital cardiac arrest in Japan. It is like what Cares would be if everybody in the country were organized and added data into Cares. If everybody in the United States, that is. Because in Japan, they are organized and they do get every cardiac arrest in. All right, so this looked at 649,000 cardiac arrests. 57% of them had mask ventilation only, compared to 43% who had some form of advanced airway. If I were to tell you that 57% of American field resuscitations were BVM only, you would think something was wrong. And you would be right. What this tells us is that the Japanese pre-hospital approach to cardiac arrest management is different than ours. So different systems. So this is not a one-to-one comparison, but it is useful information. What did they find? They looked at BVM only versus any flavor of advanced management, and they found survival with any flavor of advanced management 1.1% versus 2.9% with BVM. You would also get a brownie and a little gold star if you said, wait a second, 1.1%, 2.9% survival, even if you're saying all cardiac arrest, that is lower than around 8 to 10% that we see here in Williamson County and that we see nationally. You would be correct, and again, different system. But what we saw is advanced airway management associated with lower survival than BVM, adjusted odds ratio of 0.38. That means a 62% lower odds of survival. Now, the thing we have to think about this is, again, going back to resuscitation bias. Think about your last code. There, you were in the field doing CPR, hopefully not that fast. You're doing CPR. Your patient is a witness to arrest. As a matter of fact, he collapsed in front of you. You just happen to have the monitor on already. He's in VFib. You go zap. He says, ouch, what did you do? You never do compressions. You certainly never intubate. His odds of survival are way higher. So we have to watch out for resuscitation bias in here. Let's take a look at a randomized controlled trial. This is PART, so another secondary analysis, and they looked at those patients who had an advanced airway. Remember, in PART, it was either intubation or King LT, so they lumped those together, any advanced airway versus BVM only. And interestingly, in the BVM only group, they did something that I think is a little confusing. They also did BVM rescue, which means they were using BVM after failed advanced airway. So BVM of any flavor versus AAM of any flavor. What they found, odds ratio of survival of BVM only versus AAM was 1.96. And interestingly, BVM rescue after failed compared to AAM 7.05, even higher. Now, what I will tell you here is that I don't understand the BVM rescue. That just doesn't make sense to me. The BVM alone does because of resuscitation bias. So as I said, what we need is an RCT. So, and as it turns out, that is exactly what we got. Dr. Jabre and her colleagues gave us the CAM. Now, They are physicians in the French and Belgian system, which means their original language is French, plus or minus Flemish, depending on where they are in Belgium. CAM probably stands for something in French or Flemish, but it doesn't in English, so we just refer to this as the Jabri study. So this was a randomized control trial of EMS cardiac arrest in France and Belgium, and they randomized patients to be managed with BVM only or intubation. All right, BVM only or intubation. Now, one thing to note is this was really BVM early, because if they got ROSC at any point, all patients got intubated. The other thing to note about this is if they go to BAG, they're randomized to the mask ventilation only, and there was massive regurgitation, then they excluded them from the trial altogether and intubated them. The other thing to note about this is the French-Belgian model has physicians on the ambulance. So they pair up a doctor along with an EMT and or a nurse. The EMT and or the nurse was the one who did the bagging if they were randomized there. The physician did the intubation if randomized to intubation. So there may also be a skill level difference between the two groups. The physician was still there to run the entire code outside of airway management. Now, the other thing to notice about this is a non-inferiority study. So they're not looking for superiority. They're not saying we expect the BVM to be better than intubation or intubation to be better than BVM. They're trying to say BVM, mask ventilation only, is simpler, requires less training, and if it is no worse than intubation, then that would be a reason that we might want to use it. And when you do a non-inferiority trial, you have to set a boundary of non-inferiority. So in this case, they said, as long as mask survival from mask ventilation is no worse than 1% less than intubation, that would be non-inferior. If the confidence interval crosses that point of 1% less, then we say we failed to show non-inferiority, which is another way of saying the study didn't tell us anything. We failed to get useful data out of it. All right, so large non-inferiority randomized control trial of a physician-run system, all cardiac arrest, shockable and not, BVM versus intubation until ROSC. There were about 1,000 people in each arm. What they found was higher ROSC with intubation than mask ventilation, but it was not statistically different. And what another way of saying that is that could have been due to random chance. If we were to repeat this study 100 more times, it could have been that mask ventilation would have been better, intubation would have been better. It's just not statistically different. So 34% mask ventilation versus 38.9 with intubation. Again, no difference. Their primary outcome was CPC score of 1 or 2. Remember, that is good neurologic outcome, and they saw no difference. So the ultimately, 4.3 versus 4.2, that's a difference of 0.1%. Remember, what they wanted to see was a difference no worse than 1%. So it might look like, hey, this is non-inferior, but you have to look at the confidence interval, and the confidence interval goes anywhere from negative 1.7 all the way up to positive infinity, and that's a statistical abnormality of the type of statistics they did. So don't worry about the infinity. Just know that it's on either side. It goes from the left of negative 1% all the way up to positive. No difference. That's the bottom line. No difference. Now, they did see some important findings. They found that managing the airway, so difficult airway to manage, higher with mask ventilation than with intubation. They also found twice as much regurgitation with mask ventilation as with intubation. And they found more compression interruptions with mask ventilation than intubation. And now that was understandable because they were doing interrupted compression CPR with mask ventilation. So to sum this up, my bottom line on this Jabre study, number one, stupid non-inferiority methodology. Now I understand why they did it, and there is a place for non-inferior methodology, but when you go up to bat and swing like Casey and you strike out, people are going to look at your study and say you should not have done a non-inferiority. So this is the point where I say you should not have done a non-inferiority. Bottom line is, it does not look like there was a difference there in survival, but, big but, there were more failures to manage the airway with mask ventilation, longer interruptions, and more regurgitation. And I think this just points out managing a cardiac arrest for the duration of the arrest with a mask ventilation has multiple challenges. And I think that's a good way to summarize this. Now, let's go back and take a look at all of that regurgitation. We said almost twice as much regurgitation with mask ventilation as intubation. I think a good question is, does that matter? Why do we worry about regurgitation? Well, number one, it's icky. We don't like it on our uniforms. But the impact to the patient is aspiration pneumonia. If they regurgitate, then they are at higher risk for aspirating and getting pneumonia. So this study was a secondary analysis of patients in that CAM trial who survived for at least 12 hours, and they randomized them. They looked at them between intubation and BVM, and they said, was there any difference in actual aspiration pneumonia? And what they found is no difference. So we know it's still icky, but it does not seem to be causing more pneumonia. So maybe it doesn't matter. So that's the information on mask ventilation. The early observational data said mask ventilation is way better. Way more people survive if they're managed with a mask only. But that resuscitation bias, it turns out it was a really, really big deal, because when you randomized to mask versus intubation, no difference. And that is one more indicator resuscitation bias is real, and we have to pay attention to it. All right, let's get to the question that you have been wondering. When, Jeff, are you going to get to the real stuff? Should we intubate? Should we use the supraglottic? Do you have to pry my cold, dead fingers off my laryngoscope? Let's get to it, shall we? First off, we're going to talk about the non-randomized controlled trials. So observational stuff or secondary analyses of other randomized controlled trials. First off, we're going to talk about Rock Primed. Rock Primed was a randomized controlled trial, but it did not have anything to do with intubation. It was about early defibrillation versus late defibrillation, and then some ITD stuff. So what they did is they took all of the data collected for that trial, and then we know that some patients were managed with a supraglottic because some of the departments had a protocol that said drop a King LT first or drop an iGel first. Probably not an iGel based on when it was done, maybe some other type of supraglottic. And others said intubate first. So they took that data and they broke it up into groups who happened to be managed with a supraglottic and those who happened to be managed with an intubation, and they compared the two. And we're looking at about 10,000 patients, 81%, as we would expect with what we know of American EMS, 81% managed with intubation, 19% managed with a supraglottic. They looked at the difference: functional neurologic survival, 4.7 intubation, 3.9 supraglottic. That's an adjusted odds ratio of 1.4, and that was statistically significant. They also looked at complications, and what they found is that there was no difference in complications. So this study would suggest that survival is actually higher with intubation than supraglottics. So let's look at another observational trial. This was the Cares Registry. So the Cares Registry is the things that we participate in. Every one of our adult non-traumatic cardiac arrest takes a section of our chart and it puts it up into the cloud in a well encrypted and secured environment, by the way, at a server at Emory University. This is Cares. It's the National Cardiac Arrest Registries. That's the Cardiac Arrest Registry to Enhance Survival. So all of our codes go there. And what I will tell you is that is incredibly useful information, because not only does our data go up there, but every time it goes up to the cloud, One piece of data is which hospital we transported to, if we transported. And as soon as we put that information in, it starts sending emails to the cardiac coordinator at that hospital. It says, put in outcome information, put in outcome information, put in outcome information. And it gets to be really annoying until they do it. So the coordinator at the hospital then puts in additional data elements into this secure web form. So now we know what happened to that patient. Did they survive? Did they survive till discharge? What was their neurologic outcome at discharge? And that is incredibly important. So using this Cares database, national data, Jason McMullen and his colleagues looked at it and said, let's compare those who were intubated to those who had a supraglottic airway versus those who had nothing. In other words, BVM only. Now in this group, 52% were intubated, 29% had a supraglottic, and then 18% had nothing. BVM only or BVM after failure. What did they find? 10,000 patients. Again, they found if you compare intubation survival to supraglottic survival, 44% higher odds of survival with intubation. And that's neurologically intact survival. Now, if you compare nothing to any advanced airway, again, just like what you would expect because of, say it with me now, resuscitation bias, that the BVM only will do better, and they did. Adjusted odds ratio of functional neurologic survival, 4.24. All right, so bottom line, survival with BVM alone, way better than either intubation or supraglottic. But if you do any sort of advanced airway, it's intubation over supraglottic. Again, we have to be thinking about resuscitation bias. So we've talked about multiple observational trials. So there have been some RCTs in here that probably really honestly aren't worth mentioning in light of the good data we have. But up to this point, what we need, multiple trials showing different things. We need a systematic review and meta-analysis that combines all of these papers together to get a bigger sample size and come up with the answer. That's exactly what Dr. Benoit did here. He had 10 papers, 35,000, a little less than, 35,000 people in cardiac arrest getting intubated versus 41,000 with a supraglottic. He did all the things and the maths, and he found better survival with intubation. All right, let's get to the good RCTs here. We're going to start off in the UK on the other side of the pond. We're going to look at Airways 2. This was a large British multi-center, so multiple EMS systems, randomized controlled trial comparing intubation versus iGel. Now, the way they randomized is they didn't randomize patients, they randomized paramedics. So they asked for volunteer paramedics, and they got a lot. And if you volunteered, what you were saying is, I agree to change my initial airway management of cardiac arrest to whatever you assign me to. And if you assign me to intubation, every patient I see in cardiac arrest for the duration of this study, I'm going to intubate first. If you assign me to iGel, everyone's going to get an iGel. I like this methodology because you're doing the same airway time after time after time. You're not switching back and forth, and you're probably maintaining competence a little better at it. All right, so that's what they did. They randomized paramedics. So basically, they're getting two groups of patients who should be otherwise equal. One is getting intubated, the other is getting an iGel. Their ultimate outcome, primary outcome, functional neurologic survival at 30 days. Great looking study. So what did they find? So they had around 4,800 patients that got assigned to intubation, 4,400 that got assigned to a paramedic who's doing iGel. Let's talk about some of the big findings here. First off, success. They did not report first pass success. Shame on Dr. Binger. They should have. If you dig into multiple supplements like I did, I will tell you that their first pass success, not so bueno. It was slightly better than the next study we're going to talk about, but not great. Way lower than our survival here at Williamson County, or our first pass success here at Williamson County. What they did report is success within 2 attempts. That was 79% with intubation, 87% with iGel. Way higher with iGel. They also looked at regurgitation, so no difference overall. Aspiration, no difference. Airway loss, so you place the airway in and it becomes dislodged almost twice, actually more than twice as much with the eye gel than the intubation. Their ultimate outcomes, so ROSC, there was no difference in ROSC in their primary outcome. Neurological intact survival at 30 days, no difference. So this trial showed no difference in functionally neurologically intact survival between eye gel and intubation. And this is why it's important to do randomized controlled trials. Sometimes early evidence with observational trials will tell you one thing, and then you do a really good randomized controlled trial where you're controlling for all the variables and you find a different thing. In this case, no difference. There were some caveats to this. If you look at only those patients who actually got an advanced airway, so one was actually placed, there was improved survival. Although it wasn't large, there was improved survival with the eye gel, 3.9 versus 2.6, if you look at only those patients who had some type of advanced airway. All right, again though, the primary outcome is what matters. That's what the study was designed for. No difference. So that's over on the right side of the pond. Let's come on over here to the left side of the pond to the US, and let's look at PART. So PART stands for the Pragmatic Airway Resuscitation Trial. This was Dr. Wang's trial, 27 US hospitals with multiple agencies. The two largest agencies, Milwaukee Fire Department and Fort Worth's MedStar. So they were looking again at adults with non-traumatic cardiac arrest. This time they randomized the system. So they would do block randomization. So your system would intubate on the first attempt for 3 months, and then you would switch to a King LT for 3 months. So everyone in the study switching back and forth, intubation only, King LT only. King LT only, intubation only, no additional training as part of the study between these. So I kind of have a concern because fundamentally I think performance matters. But let's take a look at what they saw. Primary outcome here, 72-hour survival. So they had around 1,500 patients in each group. Now, if you look at the fundamental differences between the groups, they were really pretty equal in terms of age and gender and initial rhythms, just like you would expect with a randomized controlled trial. But just by happenstance, the group in the King LT had a higher proportion of really short response times, meaning under 4 minutes. 28% of the patients who got a King LT had a response time under 4 minutes. 21% of patients with intubation had a response time under 4 minutes. And if you just ask yourself, in cardiac arrest only, because I'm not going to argue response times matter in anything else, but in cardiac arrest, if you have a response time under 4 minutes versus over 4 minutes, do you think that would improve or decrease your patient's odds of survival? You'd think, get there faster, they're probably going to survive more. So just knowing that, we would expect that maybe there is a bias towards the King LT group. That's all I'm saying. Next up, first pass success, pretty decent with King LT, 90% of the time. When it comes to intubating, these boys suck. 51.6% first pass success with intubation. Now, I don't mean to be judgmental because I think overall, most EMS agencies suck with intubation. Now, I will tell you this was almost exclusively direct laryngoscopy. Very, very few video laryngoscopes in use here. About 40% used a bougie with their direct laryngoscopy, but more about that in a bit. Just know first pass success, really, really bad. All right. Some of the things that we found out is that there was no difference in displacement between King LT and intubation like there was with the eye gel. And I think some of our experience with the eye gel is it has a tendency to try to come out. So you really got to work on keeping it back in. Now, the interesting thing with this is my purely anecdotal experience is when I try to intubate after someone has had a King LT, the airway looks like crap. It is all edematous and traumatized, but they didn't really see that in this paper. And this was a randomized controlled trial, so maybe I had some form of bias there. Bottom line results, remember primary outcome of the study, 72-hour survival. It was 2.9% higher with King LT than intubation in their primary analysis. So bottom line for this paper, better survival with King LT than intubation. This was an unadjusted analysis, and that's the way they planned it, unadjusted analysis. Do you remember that thing about response times? Faster response times in King LT than intubation. And we would expect faster response times to bias towards survival in the King LT group. This did not adjust for that in the primary analysis. Now, they did run just as part of what's called a sensitivity analysis. In other words, what would happen if you did? Well, they did, and it turns out no difference. So when they ran an adjusted intention to treat analysis, that benefit became non-significant. When they did it as a per protocol analysis, non-significant. Time to first airway management was definitely faster with the King LT than intubation. However, part of that was likely to be a function of King LTs being deployed on first-in engines as opposed to intubation always being on ambulances. So I'm not sure what to make of that. Interestingly enough, 33% of the intubations were changed in the emergency department. So they pulled the tube out and put another one in. I don't really understand why they did that. Something's not right about that. And I don't mean that they were trying to pull something over on us in the trial. The trial was a very well done trial. It just means I don't understand why they did that. Bottom line on this trial is it shows improved survival with King LT versus intubation in the setting of really crappy first pass success. I think the one thing we can say from both of these two trials is supraglottics are probably no worse than intubation. All right, so we have two trials going on. What we need now, three trials really. We have the Jabre study of BVM versus intubation. We have the Airways 2 study, intubation versus iGel, and we have the PART study, which is intubation versus King LT. What we would need here is a way for us to do some fancy maths and compare BVM to intubation, BVM to supraglottic, BVM to intubation, intubation to supraglottic. That would be called a systematic review and network meta-analysis. And if you've never heard of that, don't feel bad because I was a peer reviewer on this paper and I'd never heard of it either. It took me an awful lot of studying. One thing I will tell you is it ends up with really cool graphs. And the second thing is basically it's a way of combining these studies together. Let's just go with that. So what they found is supraglottics have no difference in survival when compared to BVM. There is no difference in survival between supraglottics and intubation, and there's no difference in survival between intubation and BVM. So basically, everything is a wash. And these were done including PART and Airways 2. All right, I want to pick on PART alone because that was the one study that showed improved survival with a supraglottic. Let's just assume that survival difference is real, and in that study, I think it absolutely was real, except for the whole adjusting thing. What might account for those differences? So one, the response times, talked about that. Second, crappy first pass success. Third is interruptions in compressions. Maybe we interrupted compressions more with intubation than with supraglottics. So let's take the compression interruption first. Does that matter? Well, this was a secondary analysis of CAM, and they looked at the compression fraction over the entire code at different times between intubation and BVM. And what they found is compression interruptions early on in the code, as in around the time when they were intubating, was higher with intubation. But from then on, it was actually higher with the BVM group. So what this is telling us, more interruptions with intubation. Now, they did not say whether the standard of care there is to intubate without compression interruption. So we don't know. Next up, we're going to look at another secondary analysis of the ROC primed study, and we're looking at only those patients who had CPR metrics. So can't analyze CPR fraction if you ain't got no CPR metrics. And again, of all patients in Rock Prime with CPR metrics, they separated them out into intubation versus supraglottic. The majority of patients were intubated. What they found was there was more compression interruptions. Another way of saying that is a lower compression fraction with intubation than there was supraglottic. So this paper would certainly suggest there are more compression interruptions, and maybe that is what is doing it. This is another study. This one is a secondary analysis of PART that basically looks for the same thing. Was there a difference in compression fraction between LT and ET? This says no. So this paper is of the PART trial and suggests that that ain't the difference. So does first pass success matter in PART? So this was a study that looked at that, and the way they did it is less than satisfying. And I have to admit that they, in this case, I was one of these authors, so sort of my fault too. But what we did is we ran a logistic regression controlling for all the things, including response time. And one of the factors was intubation versus King LT. But we added in another factor, which was first pass success with whichever device you used. So I think this is a bit of a tangential way of assessing this, and that's my problem with it. I wanted a direct comparison. But what we found is with that, there was improved ROSC with first pass success, but nothing else. No improvement in 72-hour survival, no functional survival. So this analysis, even though I don't much like it, and I didn't really like it before the results, would suggest that's not what is driving that 2.9% improved survival. So let's take a look at first pass success in another study. This was a study of South Korean emergency departments, so cardiac arrest in a great big hospital in Seoul, and they looked at first pass success versus no first pass success, failed first pass success. And what did they find? They had a first pass success rate of 85%. Now, this is emergency physicians in Seoul. And they found an adjusted odds ratio for survival of 0.4 for no first pass versus first pass. In other words, 60% lower odds of survival if you miss it on the first attempt. They also found that failure of first pass was associated with approximately 3-minute delay in ROSC. Now, I don't know that that's clinically meaningful, but a 60% decrease in survival with failure to get first pass success is important. Now, again, this is not a randomized control trial. PART is a randomized control trial. We have to consider that, but this would also suggest maybe first pass is what was driving those results. Let's take a look at some EMS data, shall we? Why, yes, Jeff, I think we shall. Off we go to the Pacific Northwest. Medic One in Seattle looked at just this question, hot off the presses. This was published in the last 2 weeks. So Dr. Murphy and his colleagues looked at all of their Cares data. So remember, Cares is that registry. All of the data goes up there. Seattle is also a part of Cares. So they have outcome data. And then they combine that with ESO, because they also use ESO, and they know how many attempts it took to get the patient intubated. And there, they do something similar to what we do. They analyze the biometric data after the event and correlate that with what was said in the chart about first pass versus not. They also have audio recordings of their life packs that they use. They turn on all cardiac arrest, and they use those for quality improvement. So the bottom line is, if the medic said they got it in on the first attempt, the medic got it in on the first attempt. There was lots of verification. So what they did is they looked at overall survival, shockable, non-shockable, bystander, non-bystander, all the codes in adults and non-trauma. And overall, survival was 8.1%. Now, I do have to point out our survival was 10% overall. Just wanted to throw that out there. I'm not going to bring up, by the way, their Utstein survival, because it's like way higher than ours. But we look better in this outcome, so I'll bring that up. So overall neurologically intact survival was 8.1 regardless of number of attempts. And then they took the entire group and broke them up into buckets based on the number of intubation attempts. And they found that if you got a first pass success, you got it in on the first attempt, your survival 10.8%, so higher than overall survival. If you got 2 attempts, succeeded on the second attempt, survival 4.3, 3 attempts 2.6, 4 or more attempts 2.0. So what we see is that survival with first pass success 10.8 drops to 4.3, then 2.6, then 2. So you see a really big drop off after first pass, and then it flattens out. They did an adjusted odds ratio, adjusting for all the things, age, bystander CPR, the things. 59% decrease in the odds of survival with each additional intubation attempt. This study is really important to me. What this is telling us is there is a direct association between first pass and survival. The more attempts you make, the worse your chances of survival. And that, to me, you're never going to get, by the way, a randomized control trial of you're going to get randomized to succeed in 2 attempts versus you're going to get randomized to succeed in 1 attempt. You can't do that. So there is still the specter of resuscitation bias here. But with that in mind, with that limitation in mind, I think this is real and I think it's important and I think it goes a long way to explaining that 2.9% improved survival in part. Also, it tells me we need to look at our data. So I am now in the process of doing this exact thing, seeing if there's a difference in survival between first pass and not first pass. And in our system, we get 2 attempts. So it's really first pass versus second attempt. And if I see a big drop off like this, I'm going to go 1 attempt and then you move to an iGel. So I don't know the results of that yet. We're working on it. The question here, in Seattle, this was all direct laryngoscopy. They do not have video as of yet. Dr. Sayre is certainly looking at that. He thinks maybe video will work. So in DL, does using a bougie in cardiac increase first pass success? And the answer, yes. I realize that's not a shock, but yes. There was, however, no difference in survival. What about video laryngoscopy? So this was a study that was an analysis of the ESO collaborative, and I'll admit this is another study I was a part of. And we looked at something that I didn't honestly expect to make a difference. We said, does VL have an impact on first pass success? And I greatly expected it to do that. But does it have an impact on overall success? And I wasn't convinced about that. What we found, we looked at 22,000 cardiac arrests, 26% of them used VL, the remainder DL. And we saw that first pass success was higher, odds ratio 1.5%. There was improved ROSC, but no improvement in functional neurologic survival. All right, so VL improves first pass success. What about in the hands of physicians? So this was a Japanese registry in the emergency department, cardiac arrest, VL versus DL, and what we found, higher first pass success with VL than with DL. We found better views, and we found fewer esophageal intubations. What about in the hands of experienced clinicians? And let me define that for you as old ER doctors, sadly like me. What does an old ER doctor mean? That means they trained and got good with DL, maybe not so much with that newfangled VL. In this group, this was an RCT in Seoul looking at experienced physicians, and even in their hands, what they found is 94% first pass success VL versus 87% with DL. However, because there was a small sample size, that was not statistically significant, but they did find more interruptions in compressions with DL versus VL and a higher proportion of interruptions in compressions. So even in the hands of people who are really, really good at DL, there's less interruptions in compressions with VL. All right, a couple of things real quick. What about, do you do anything with the airway once you have it secured with either an intubation or a supraglottic? And in speaking with Dr. Wang, just sitting around a bar trying to figure this out, He thinks that we may bag patients faster if they have an intubation versus a King LT. Now, we don't have any evidence of that yet. One of the reasons is that we don't have a great way to measure respiratory rate, so we don't know. But what we do know, and this is the reason I wanted to bring this study up, is that hyperventilation, for whatever reason, in cardiac arrest is bad. So how do we know that? Well, this was a study in pigs, and we see some similar results in humans. Interthoracic pressure goes up the faster you bag. So they randomized these pigs that they put in cardiac arrest to getting ventilated at 12 seconds, 20 seconds, or 30 seconds, and they measured interthoracic pressure, and they measured coronary perfusion pressure, and they found, as you might expect, the faster you bag them, the higher the interthoracic pressure. So why do we care about interthoracic pressure? Because it affects preload and it affects coronary perfusion pressure. So the higher the interthoracic pressure, the lower the coronary perfusion pressure. And sure enough, they found a drop in coronary perfusion pressure with hyperventilation. That is the reason it's really important for us to pay attention to the metronome and not hyperventilate our patients. Hyperventilation is bad. Just say no. All right, what about that ITD thingy, the rescue pod? Does it make a difference? This is one of the things that was being studied in Rock Prime. So they did randomize patients to an ITD versus a sham ITD. In other words, it was a device that looked like an ITD, had the little flashy thing, but did not actually do the ITD thing, the impedance threshold device. So what do we find? Overall functional neurologic survival, no difference. ITD did not improve survival in Rock Prime, the study that was designed to look for that. There have also been other randomized control trials, and they did not find improved survival with the ITD alone. And that is why, if you do a careful search of our ambulances, you will not find ITDs. But wait, Jeff, wait, what about if you use the rescue pod with the rescue pumpy thing? In other words, the toilet bowl plunger. So the idea behind this is if you are creating negative interthoracic pressure, when your hands come off of the chest, you come back up to neutral position. If there were a way you could actually pull the chest up a little bit more and do active decompression and decrease interthoracic pressure, that might increase coronary perfusion pressure and lead to improved survival. And in fact, it does that in the pig lab. Studies of the pump alone by itself without the ITD have not shown benefit. What about if you do the two things together? And this was the rescue trial, randomized control trial, reasonably well done, rescue pod plus the rescue pump. It did show improved survival. So what that shows is that if you do the two things together, active decompression with the ITD improves survival. So let's go ahead and summarize what we covered. I know this is a lot of research, but I wanted to give you essentially a state of the science when it comes to airway management of cardiac arrest. So, number one takeaway, we need to put less focus on initial airway management. We need to focus on minimally interrupted, high quality chest compressions, good rate, good depth, good recoil, staying on the chest for as long as we can. Get right back on the chest as soon as you defibrillate. Don't wait. Don't check for a pulse. Get defibrillated as quickly as possible. Get epinephrine, at least that first dose in, rapidly. In the meantime, we need to delay intubation. You can do passive oxygenation in the right patients, BVM in the wrong patients. So what I mean by that is don't intubate anybody early. If they arrest in front of you, oxygen probably isn't the issue, so just do passive oxygenation. High CO2 is not likely to be a problem. If they've had a respiratory disorder or they've been down a while, start bagging, but don't intubate early. Okay, so what do we do if we're going to manage it? Well, we know BVM works, at least early on in the code, but at some point we probably need to switch just for logistics and how the code works, if nothing else. When we place an advanced airway, do not interrupt compressions. I can't say that enough. Do not interrupt compressions to intubate. Just don't do it. Next up, the literature would suggest we need to limit our number of intubation attempts. Now, we already do that in our system. We limit it to 2, but based on the strength of that Murphy paper from Seattle, I'm doing a reanalysis. We may limit it to just 1, depending on what our data shows here. If you're going to intubate, for the love of God, do it right. Be good at it. Have a high first pass success, like I might add, we do here in Williamson County. If you're not going to be good at it, and your system, not individual medics, if your system is not good at it, and there are a lot of reasons that's not something you should be ashamed of. It takes, as y'all know, a lot of training to maintain our first pass success in Williamson County. If you can't do that, use a supraglottic. At worst, it's probably about as good as intubation. And I think we have pretty good evidence for that. For other systems that haven't already made the leap like we have, you probably ought to be using video laryngoscopy. And then trust but verify. And what I mean by that is, if you think you are the best system in the world at intubation or at cardiac arrest or at anything, that's great, believe it, but verify it. Trust but verify. In other words, measure and look at your data. All right, that is what I have. That is the state of the science as of September 3rd, 2021. That's what the literature says about managing an airway in cardiac arrest. Guys, I hope this has been helpful information for you. As always, feel free to reach out, drop me an email, jjarvis@wilco.org. Hit me up on Twitter at Dr. Jeff Jarvis. Or if you happen to know my cell phone, like everybody in the Williamson County system, just give me a call. Thanks a lot. Have a great day.